This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 33, Medical Resuscitation. Key Concepts. Upon completion of this chapter, you will understand that adequate delivery of oxygen to the tissues is the primary goal of medical resuscitation, that paramedics develop the skill needed to distinguish a sick patient from a non-sick patient, the importance of using an algorithmic approach to rapidly identify goals, since multiple medical conditions can lead to a change in oxygenation at the tissue level. Chief concerns: adequate oxygen delivery, clear and unobstructed airway. The pathway must be present for oxygen to enter through the mouth or nose, down to the alveoli to the lungs. Very simply. Adequate oxygenation. Movement of oxygen into the lungs across the alveolar membrane and into the blood. Adequate ventilation. Movement of air in and out of the lungs. Adequate tissue perfusion. Adequate nutrient supply to the body cells, essentially in transportation of oxygen, glucose, and other substrates required for cell function. Components of the circulatory system that affect adequate tissue perfusion are the vessels, the heart, and the amount of fluid in the circulatory system. It may also be affected by other chemicals and toxic substances that impair cellular respiration. Initial patient contact, sick versus not sick. This is figure 33-1. A seasoned paramedic will often decide if the patient is sick or not sick from the doorway. 33-2. Paramedic differential diagnosis for the patient with altered mental status. They could be hypoxic, they could be hypoglycemic, they could have an infection or be septic, they could have a toxicological concern, including alcohol or recreational drugs, or they could be hypotensive. Figure 33-3, observations from the initial contact which indicates a sick patient. The patient does not make eye contact, bubbling or any gurgling in the airway, snoring respirations, tripod position, agonal respirations, cyanosis, pale gray or mottled skin. Clear and unobstructed airway. The first key factor in oxygen delivery is assessment. The signs of the airway is in jeopardy. If they're snoring or gurgling, the signs that the airway is either partially obstructed from some foreign material or is obstructed by extra airway tissues, like in the case of anaphylaxis. Inspect the mouth and nose for foreign materials. Suction and open the airway. Next picture we're going to look at here is figure 33-4, and paramedic assessing a patient for a gag reflex. A good way to facilitate this is by the use of a tongue depressor. However, please have suction at ready. Management plan. Ensuring unobstructed airways. So there's a variety of methods. Medication facilitated intubation. Attempt intubation using sedation only or proceeding with sedation and paralysis using a supraglottic airway instead of an endotracheal tube. Intubation with sedation only as opposed to sedation and paralysis often does not provide for adequate visualization. Using the book's data, sedation alone was not liked as opposed to sedation and paralysis. The paralysis version, or the use of a paralytic, was according to the book's data, was better at ensuring an airway. Multiple intubation attempts brings consequences, and the consequences are decreased likelihood of success, an increased airway trauma risk, and increased hypoxia or likelihood. Adequate oxygenation. Without tissue oxygenation diffusing into the blood from alveoli, tissues will not receive enough oxygen. In the assessment, the patients who are cyanotic, impending respiratory failure, or need immediate attention, an indicator of this would be an altered mental status. Management plan. Critically ill patients, provide them with high flow oxygen or high concentrations of oxygen until stabilized. Patient with a COPD history often need increased oxygenation once stabilized. The FiO2 or oxygen percentage can be titrated. Supplemental oxygen delivery methods are things like non-rebreather, CPAP, or continuous positive airway pressure, a BVM device, or invasive airway technique like endotracheal intubation. Adequate ventilation without adequate movement of air in and out of the lungs. Oxygen and carbon dioxide diffusion will not occur. Assessment. Impending respiratory failure needs immediate attention. Signs of increased work of breathing, increased chest wall excursion, inability to talk due to respiratory distress, sternal retractions, rib retractions, the use of abdominal muscles, and the use of the anterior neck muscles with inspiration. Management plan. Increased work of breathing may require ventilatory assistance. CPAP improves the work of breathing by splinting open the alveoli. Be sure your patient has their own respiratory drive before applying CPAP. Considerations. Keep the entire clinical picture in mind. The patient who has overdosed on opiates, for an example, depressed respiratory drive can often be managed by assisting ventilations with a BVM mask until an appropriate dose of Narcan can be administered. Consider other tasks involved in resuscitation. Multiple acute issues may be more appropriate to utilize an alternative invasive airway technique that is inserted more rapidly. If they have multiple causes or multiple acute issues simultaneously, getting them ventilated would be the key. Adequate circulation, a little more challenging. Physiology of underlying critical illness, one of these things are going to be adjusted, whether it be vascular tone, the heart's ability to contract, or the circulating blood volume. Assessment, skin color and temperature. Poor skin color is a visual clue that the circulation has been diverted from the skin or shunted to the core. The use of pulse oximetry, SpO2, and the quality of the oximetry waveform. We got a picture here on the next page we'll take a look at. Subtle clues in the vital signs, widening pulse pressures or tachycardia, 12-lead electrocardiogram or 12-lead ECG. Determine if the cause is inadequate perfusion is myocardial infarction. And this is figure we're fixing to look at 33-5, and it's a variation between a normal waveform and an abnormal waveform. This one here probably isn't giving you the appropriate reading. However, if the mapping's good and it can see the pulse, the reading would probably be appropriate. Management plan. Components. The pump. We should look at the heart rate, the rhythm, and its contractility. Patients who develop primary cardiogenic shock may require a balloon pump inserted from a cardiologist or a counterpulsation device. So this would assist the heart's ejection and also perfuse the heart better. Volume, circulating blood volume or lack of. The lack of blood volume can occur either through fluid loss or through blood loss. Severe dehydration can also be a factor in this. It can be caused from a variety of reasons, diarrhea, just dehydrated from not having enough water intake, and so on. Blood vessels, vascular system and tone. Systemic vasodilation, common end result in septic shock, anaphylaxis, and adrenal crisis. Vascular tone, affected by natural steroid production. Early goal-directed therapy, standardized treatment algorithm are used to assist sepsis to ensure adequate perfusion. And what we're looking at here on the next page is the next table. And this is an algorithmic approach to the management of inadequate circulatory status. So we start this off. Maximize oxygenation. Did it improve? Well, yes. Goes all the way down to the end. If no, assess heart rate contractility and control if too fast or too slow through the use of pharmacology, electricity. If decreased contractility or STIMI, consider dopamine or dobutamine. Did that improve? Yes or no? If the answer is no, assess volume status and replenish it. This would be fluid boluses. Did it improve? Yes or no? Assess for distributive causes and vasopressors if no response from 2 liters of saline infusion. Vasopressors used would be epinephrine, norepinephrine, phenylephrine, and anaphylaxis. It would be epinephrine, and adrenal crisis we would consider steroids. So just problem-solving algorithm here. This is figure 33.7. Systemic vasodilation causes a drop in blood pressure because the circulating volume is not sufficient to fill the volume of the blood vessels, and that is because blood vessels that started off like this from whatever cause of the dilation now are this, so your container is larger. These are toxins and common antidotes. Calcium channel blocker, if that's the toxin, then calcium is the antidote. Beta blocker would be glucagon, and that's because we want to incite gluconeogenesis. Opioid, naloxone. Tricyclic antidepressants, sodium bicarbonate. Aspirin, sodium bicarbonate. Acetaminophen or Tylenol. N-acetylcysteine, which is like mucomist. Toxic alcohols, fomepizole, organophosphates and nervagents, atropine and pralidoxamine. Cyanide, amyl nitrate, and sodium thiosulfate. Digoxin would be digibine. In conclusion, an algorithmic approach to the care of the critically injured patient, focusing on the identification and aggressive management of the critically ill patient early in the encounter, will improve the patient's outcome. The end in caring for all critically ill patients, regardless of their underlying condition, is to deliver oxygen to the organs and tissues. Maintaining a focus on this goal will help the paramedic be successful in treating the sickest of medical patients. References to this were taken from Myers, Professional Paramedic, Volume 2, Medical Emergencies of Delmar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandcc.edu or 405-219-7613. Thank you.